This is Hannah Galvin presenting on behalf of myself, Chetan Sarabu, and the Protecting Privacy to Promote Interoperability Workgroup on promoting safe health information exchange through granular privacy protections. The Protecting Privacy to Promote Interoperability Workgroup is a national multidisciplinary workgroup of over 160 experts from across the industry. It was formed in 2018 and formalized through a charter process this past year in 2020. It's supported by IHE USA, as well as HIM, and the Drummond Group Trusted Test Lab and Certification Body. Its member stakeholders include healthcare provider organizations and institutions, as well as individual healthcare providers, clinical and technical professional societies, standards development organizations, health IT vendors, health information exchanges and interoperability frameworks, payers, government, contractors, both government and non-governmental contractors, privacy law and ethics experts, as well as patient advocates and others. I'm going to start today by reviewing a clinical use case. This will help us to frame the problem and describe the current challenge that the Protecting Privacy to Promote Interoperability Workgroup aims to address. This is Paul. Paul is a 72-year-old retired teacher who comes in for his annual physical. He has a history of high blood pressure, gout, atrial fibrillation, and has had 3 transient ischemic attacks over the past couple of years. Paul also has a history of alcoholism and has had a few relapses over the past decade since his son was killed while serving overseas. An underlying depression was diagnosed, and he is improving with the help of counseling and an antidepressant. Paul is accompanied today by his wife, Donna, who's also his healthcare agent in waiting, meaning that she's designated as his healthcare agent, but doesn't currently have decision-making capacity in that role. Donna tells you that Paul's been having some difficulty with his short-term memory, including making it to some of his medical appointments. Paul is on an anticoagulant called warfarin due to his atrial fibrillation and the transient ischemic attacks. He requires frequent labs in order to monitor his dose. And Donna's particularly concerned that Paul missed one of these appointments recently. She asked if there's any way that she can gain access to his electronic medical record in order to make sure that he gets to his appointments, and also to review his appointment notes, which come to his portal account, in order to make sure that there are no medication changes, which he may have forgotten about, and to basically make sure that he's getting the right care. When you meet with Paul alone, he expresses concern and even some resentment about this suggestion. He tells you that he hasn't discussed his relapses or his depression diagnosis with Donna, and he doesn't want her, quote, prying into his medical affairs. He says that this is none of her business. Once he calms down, he does admit that it would be helpful for her to have access, but only to certain information, like his clinic appointments for his lab checks. But he's really clear that he doesn't want her having access to all of his information, including his full list of medications, because this includes his antidepressant. He doesn't want her seeing his full list of diagnoses or all of his appointments, including those with behavioral health. During this visit, Paul also tells you he's been having some trouble seeing, and as you place an optometry referral, he says, this eye doctor isn't going to know about this stuff, right? He asks that you prevent any information about his mental health or his substance use disorder going to his eye doctor as well. He doesn't feel that provider needs to know about his mental health. So this case really poses significant privacy challenges, and these are confounded by the complexities of providing optimal clinical care, as well as the current limitations of our data standards and our health information systems infrastructure. As we think about framing the issue, the ability to share an individual's protected health information, whether it's between providers and healthcare entities or between patients and their families, can really only be freely accomplished when we establish some agreement around how to appropriately balance the need for privacy and patient safety, how to actually identify sensitive information within a record. And this is very subjective. What is sensitive for one person may not be sensitive for another person at all. For Paul, his behavioral health diagnosis, his alcoholism, those are very sensitive concepts for him. For another patient, those may not be sensitive in any way. From a technical perspective, how do we tag that data as sensitive? How do we apply labeling or tags to that data appropriately? How do we protect that information in the home record? And then once it's been transmitted, how do we protect it? How would we display such data or convey that it's not being displayed, convey that it's being redacted in some way? And then how do we share or reshare that sensitive information in an appropriate manner? Currently, there's not a lot of agreement about any of these matters. Add to that the numerous stakeholders in this space, each with their own perspective, and then consider the many different types of data and the labyrinthine flow of information to both internal and external data handlers. Questions of data ownership arise. Does the patient own their data, or does the provider or health system that generated that data, or both? There are issues of how best to define access control. Should it be at the level of the individual user? Should it be role-based, specialty-based, or defined even more broadly? Complex and heated questions arise around a health entity's ethical responsibility to provide the safest care possible versus a patient's individual right to privacy with informed consent. Finally, the development and implementation of these standards is complex, requiring informatics expertise and resourcing. These challenges have led much of the industry to deem this an issue that's too big to tackle and raise a white flag and deprioritize addressing this issue in favor of other potentially more urgent requests. But kicking the can down the road has led us to end up in a situation in which many organizations have instead enabled blunt privacy protections in order to comply with their state laws. In these cases, patients with certain health conditions have to choose whether to share all of their data or none of it. By setting up these conditions, we may be inadvertently producing healthcare disparities. So looking at patient A in this diagram has no sensitive data. If patient A ends up in a car accident and goes to the emergency room, all of patient A's data flows. So the treating provider in the emergency room has access to patient A's medications, problem list, immunizations, allergies, so that she can provide him with optimal care. Patient B, who has some sensitive data in his chart, may, according to state law, require additional consent in order to share that data. If the technical capabilities are not there and the patient in this situation cannot provide additional consent, when this patient goes to the emergency room, none of the data may flow. And in this case, patient B's provider in the emergency room may not be able to provide optimal care because the patient's medications, allergies, et cetera, don't flow due to these blunt privacy protections. The only material difference between patient A and patient B in this case is that patient B has a sensitive condition, in this case perhaps a mental health condition. But that's limiting interoperability for this patient and therefore optimal care, and this is precisely how disparities are created. So in 2018, we started working to convene this multidisciplinary work group of stakeholders, the Protecting Privacy to Promote Interoperability Workgroup. Our deliverables are to develop a set of internationally accepted use cases. These have been finalized as well by the end of January, actually, but by the end of this past January, these have been finalized. And they include an adolescent use case that involves reproductive health issues, a geriatric use case, similar to the one that we discussed with Paul, that involves behavioral health and substance use disorder, A social determinants of health use case that we are aligning with the work that the Gravity Project is doing, which also involves data going from and generated by a third-party health app, mobile health app, as well as a case of shared data between a maternal and child medical record. The group has started to draft a minimal set of potentially sensitive data elements and map these to USCDI, as well as to trace the flow of these data elements through the use case workflows. The work group includes members of the HL7 security work group, responsible for the data segmentation for privacy, or DS4P FHIR standard, and the underlying healthcare privacy and security classification system, which is the security labeling that underlies DS4P. We're leveraging the use cases as a means to assess gaps in the current standards and ballot for appropriate standards revision, as well as to propose development of policy-driven security labeling, policy-driven security labeling service to automate tagging of data. As we've seen, even after such standards are published, there are significant challenges to implementation. While the rare organization may have the resources and informatics talent to take on such a project, most organizations find that competing priorities and limited informatics and legal expertise preclude them from doing so, even if they see the clinical need. So a big part of this work is the development of consensus-driven guidance to be published in an implementation guide in conjunction with standards revision. This includes a defined, standardized terminology value set that would be applicable to our clinical use cases, an analysis of the risks and benefits of role-based, specialty-based, and user-based security, with some clear recommendations for organizations based on these defined use cases. And recommendations that are approved by the various clinical professional society representation within the work group around how best to surface this type of redacted data in the medical record and utilize it in decision support algorithms, as well as appropriate policies and procedures for emergency access to this data if needed, how best to support patient safety as well as patients' needs for privacy. This slide shows how the current work group is structured. Under the larger work group, we have several foundational subgroups, one that is focused on the development of the clinical use case and other clinical issues, one that's focused on issues of usability and patient safety, one that's focused on implementation guidance, one that's focused on standards revision and defining a terminology value set, and one that's focused on future policy considerations. We also have 3 overarching subgroups which provide insight to the other groups and to the larger group as a whole. These are focused on ethics, legal issues, and the patient perspective. In 2020, we made significant progress in formalizing the work group, establishing a charter, and determining deliverables. We established the aforementioned subgroups, and the clinical subgroup has now been able to finalize the clinical use cases that really serve as a framework for the various other groups, subgroups to work with. Moving forward into 2021, the group plans to leverage the Delphi method to achieve consensus around many of the controversial areas that we discussed earlier. Simultaneously, the standards and terminology subgroup will build out a sensitive data element story around each use case to support standards revision, as well as identify a steward to update and maintain the sensitive data value sets, such as those previously stewarded by SAMHSA. The usability and implementation subwork groups will in turn will turn the use cases into persona and usability pieces, and they will prepare storyboards in preparation for a sandbox demonstration, hopefully as early as next year. If you're a stakeholder who's interested in these issues, who would like more information about the Protecting Privacy to Promote Interoperability Workgroup, or if you have any questions about today's presentation, please feel free to reach out to Serena Mack from the Drummond Group to discuss our current activities, she can connect you with me or with the group and bring you up to speed. Thank you very much.